All right, my friends, today is day 29. Day 29. You know what that means? That means you guys have been cooking it means you guys have been cooking for 4 weeks straight, 28 days, okay? So again, the keys at this moment are to keep the momentum going, okay? The keys are not to sacrifice any ground. The keys are not to fall back into old habits. The keys are to keep pushing, okay? Exercise is like pushing a car uphill. It takes a lot of time, a lot of effort, a lot of blood, sweat, and tears to get that car uphill. But as soon as you stop pushing, you start rolling downhill. So you've already started to see the benefits of this program. Okay, you've already started to see the benefits of Pulmonary Wellness Online. However, those benefits will only deepen, will only widen, will only increase the more you do. Okay, so keep it coming. Day 29, 2 weeks to go until the end of boot camp, and then we got more in store for you. Okay, you can do this, people. You can do this. Day 29, week 5, day 1. Have a great one, my friends. Yes. Question of the day. So for today, I want to talk about something that is a very common theme for patients with cardiovascular and or respiratory disease, and that is chest pain or pressure, okay? So for today, I want to talk about the chest pain or pressure that we feel at different times, which is different than the very common theme of rib cramping or rib pain, which I will get to very, very shortly, okay? As in tomorrow, okay? However, I want to talk today about chest pain and what we should be aware of and what we need to know and what we need to let our doctors know and what should be cause for concern and what is just something that's merely uncomfortable for us. So for today, I'm joined by a very special guest. You know him as Hercules. And Hercules has agreed to work and allow me to demonstrate on him. So one of the things to keep in mind is that I always say between the neck and the belt line, okay? And depending on who you are, your belt line could be at different places along your body, okay? However, okay, my point is that between here and here, we have a lot of different body systems, and many of those body systems can cause very, very similar symptoms. Many of those body systems can make us feel uncomfortable. I'm learning a new word. It's uncomfortable, learning a new word, but that word is uncomfortable. So I'm trying to become more comfortable with uncomfortable. But back to the point. So the idea is that between here and here, we have the respiratory system, which if you have COPD, if you have pulmonary fibrosis, if you have pulmonary hypertension, you are used to having discomfort at certain points or at different points along the respiratory system. We have the heart and the cardiovascular system, okay? And that's the big one, okay? That's the one that we worry about the most. And so if you have coronary disease or if you have some other type of cardiovascular syndrome, okay, you may also be used to dealing with cardiac discomfort as well. Okay, but I want to talk about some of the differences between the different discomforts and what is okay and what is not okay. And then also we have this whole big mess in here, which is the gastrointestinal system. And believe it or not, the gastrointestinal system can also cause us discomfort anywhere in this general abdominal or thoracic area. Okay, so again, keys to know. Okay, so I would much rather you mistake gas for a heart problem than mistake a heart problem for gas, okay? So in other words, I don't want you minimizing things, and the way that we treat and the way that we keep people safe is by assuming the worst until proven otherwise. So in this case, gas is the least of our problems, okay? Your heart squeezing because it's not getting enough blood and therefore not enough oxygen, that's the worst of our problem, okay? And those are the things that it's important to distinguish between, and that's where communication with your doctor is extremely crucial, okay? I saw a question today online and it goes like this. As we all know so very well, COPD causes an extreme amount of chest pain, okay? But does anyone get angina or angina pain too, okay? Okay, so the question is, as we all know so very well, COPD causes an extreme amount of chest pain, often severe. But does anyone else get angina pains too? My doctor explained that COPD stresses the heart and does indeed often provoke angina, okay? The kind that goes down the arm into the jaw and teeth, and burning chest pain. Been having quite a bit of it during this current exacerbation. Okay, so let me just dissect that question, because I'm sure other people have the same question, because I've been asked that question over and over again and over again and over again and over again over many, many years in many different ways. So let me just talk about certain key points. First is, as we all know so very well, COPD causes an extreme amount of chest pain. Now, I don't know that so well, and I don't know if you know that so well, but I would say can sometimes cause some discomfort and can sometimes cause an extreme amount of chest pain, okay? But when I think of chest pain, I think heart. That's my wording, okay? And the wording is very, very important. And there's a lot of confusion in terms of how things are worded. And it's constantly complicated by, believe it or not, trying to dumb things down. So in other words, I saw a recent commercial for a asthma or COPD medication where the person said, it feels like an elephant is sitting on my chest, okay? When I saw this, I was like, this is bad, because the classic feels like an elephant sitting on my chest was always pointing us towards the heart, okay? So in other words, if an EMT or a paramedic comes to your home, you say, it feels like an elephant is sitting on my chest, first thought is gonna be heart, not respiratory. So I feel that that company did a disservice to anybody who may be having a heart attack and who feels like an elephant is really sitting on their chest. Okay, so again, we don't know for sure that COPD causes an extreme amount of chest pain, okay? But does anyone else get angina too? So now those are separate things, and it's important to recognize that just because you have COPD, or just because you have pulmonary fibrosis, or just because you have pulmonary hypertension, that does not exclude you from being a member or also having angina or coronary disease, okay? And one of the big mistakes that people make, even clinicians, is that for people that are used to dealing with a long-term problem like COPD, like pulmonary hypertension, like pulmonary fibrosis, everything gets relegated to that diagnosis. And so when the person has chest pain, we want to say, oh, that's your COPD. Or when the person has chest pain, we want to say, oh, that's your pulmonary fibrosis. Or when the person has chest pain, we want to say, oh, that's your pulmonary hypertension. Maybe it is, but maybe it's not. And I don't want to assume it is and find out the hard way that I was wrong. Okay, so everything must be worked up, which is why I say that cardiopulmonary patients, particularly pulmonary patients, should have an internist or a general practitioner, should have a pulmonologist, of course, but should also have a cardiologist to help distinguish what is cardiovascular in nature and what is respiratory in nature, okay? My doctor explained that COPD stresses the heart and does indeed often provoke angina. So, again, I will backtrack. COPD can stress the heart, maybe stress the heart, doesn't have to stress the heart. And you know, you can say, does every COPD patient have stress on their heart? Not necessarily, which is why I hate black and white explanations of things, because very few things, especially when we're talking about the cardiopulmonary system, are black and white, okay? And that's where you have to dissect it and dissect it. It's like when your fishing line gets all caught up, you have to take it apart piece by piece by piece by piece until finally the situation is clear, okay? But you have to have a doctor who's interested in doing that, okay? Now, for the person that has coronary disease, so for the person who we know has an obstruction of their coronary arteries, meaning that blood flow does not go to the heart effectively, okay, there's a blockage of blood flow to the heart, and therefore the heart is not getting enough oxygen, which is what we call coronary ischemia, okay? So if that person also has COPD, then by all means, when that person is under stress or strain, that can also increase the stress and strain on the heart and evoke angina, okay? But for the person that does not have heart disease, okay, and who has been legitimately worked up and ruled out having coronary disease, that person should not be getting angina under just about any circumstances. There are extreme cases where it's not even worth discussing because they're so rare, okay? The kind that goes down the arm into the jaw and teeth and burning chest pain. Okay, burning is a different story, okay? Burning is not something that is often thought of as cardiac in nature, okay? Burning feeling, stabbing, not usually. Sharp pain, not usually, okay? Been having quite a bit of it during this current examination, okay? Exacerbation. Okay, so somebody, must be one of my students, said you should be checked. You never can be too careful when it comes to the heart. Agree, okay? Someone else said, I agree, you should be checked. I have been. So the person said, I have been. I had a nuclear stress test 2 months ago, completely normal. Troponin slightly elevated, but second test came down. Seems to happen when I nebulize with albuterol. Okay, so nuclear stress test is a great test, especially for people with respiratory disease, because one of the problems that people with respiratory disease often have is that they can't walk on the treadmill enough to get a good cardiopulmonary exercise test in because they're either short of breath or their lower extremities are too fatigued. Okay, so a nuclear test should tell you a lot about blood flow to the heart. Now, troponin slightly elevated is not 100% normal. That's not completely normal, okay? So I would question that a little bit, okay? Someone else wrote, I've learned to live with it, unfortunately. I keep aspirin and ibuprofen close at hand. So again, aspirin and ibuprofen are not the treatment for coronary angina, okay? So if you have angina, the treatment is not, although aspirin can work if you're having a heart attack because it's a blood thinner and it can help with clots, okay? But aspirin and ibuprofen is not the treatment for coronary pain. All right, somebody else wrote, I wrote, COPD could cause what you are referring to if you have atherosclerosis or blockages in your coronary arteries. It does not sound like you know much about the situation, which leads me to believe that your heart has not been worked up completely. If it has, you would definitely know more. If it hasn't, would strongly suggest that you see a cardiologist for follow-up. At a minimum, I would recommend a stress test, ideally a stress echocardiogram. That's before I knew that the person had a nuclear stress test, and then he said, I had a nuclear stress test, EKG and Holter, all was fine, okay? So if you had a nuclear stress test, EKG, Holter, everything short of an angiogram, okay, and everything was fine, then I would make the case that that is not angina that you're experiencing. Okay, and the only way to take it further would be an angiogram, or what's known as a cardiac catheterization, where you can actually see the coronary arteries themselves. Now, that being said, there are times where somebody can have clean, main, big coronary arteries, meaning the left coronary artery, the left anterior descending artery, the left circumflex artery, the right coronary artery. So those are the big roots of the tree, okay, that everything comes off of. Now, there are people who have clean, major arteries, but small blockages in smaller, less significant arteries that can still cause them discomfort, okay? That's something to think about. My answer was very interesting. Very often, I'm not saying that my answer was very interesting. I'm saying that I answered very interesting, okay? Very often, the heart, lungs, and even the GI system can present with very similar symptoms. This is the reason for the workup. short of an angiogram, a nuclear stress test is the next best option because the chemicals do all the work. This is a better scenario in this situation than a treadmill test in the event that shortness of breath stops you before you reach a cardiac endpoint like angina or ischemia, the heart not getting enough blood. So you see, I agree with myself from further up. All right, if the nuclear stress test was negative, meaning no ischemia, how can this be angina, which is a symptom of ischemia? Why is this important? Because if it actually is ischemia, it very well could and should be treated and certainly worked up. And if it is not, then you can stop worrying about it, okay? So that to me is one of the beautiful things about monitoring patients so closely, is that patients are gonna experience a whole bunch of symptoms, and some of them will be respiratory in nature, and some of them may be cardiac in nature, and some of them may be gastrointestinal in nature, okay? But by monitoring you so closely, including an EKG, blood pressures every 3 to 5 minutes, oxygen continuously, okay? We get to see things in a much bigger, broader scope that is a much more complete picture. And then we can deal with patient symptoms by educating them about what's what. Now, when we talk about symptoms, okay, there's something that, there's a method of classifying symptoms that we use in EMS, and it's known as OPQRSTI, and what that means is that O is for onset. So tell me about your chest pain. Tell me what brings it on. What were you doing at the time that you experienced your chest pain? P stands for provocation and palliation, which means what makes it better, what makes it worse, what brings it on, what makes it go away. So I was walking up a flight of stairs, all of a sudden it felt like an elephant was sitting on my chest, stopped, did the breathing, went away, okay? Or I walked through the perfume department at Lord & Taylor, and next thing I know, my airways tightened up. I went outside for some fresh air and did my rescue inhaler, okay? Q stands for quality, and this is where things get interesting when it comes to the heart, the lungs, and the GI system, okay? So when we ask initially, is it sharp or dull? A pinpoint sharp pain does not usually point to the heart, okay? Likewise, anything that you can press and push on your musculoskeletal system and that elicits the same type of pain is not typically the heart. And again, the first thing we want to do is rule out the heart, okay? The heart is usually described as a squeezing, as a pressure, as a pushing, and very often people will make this. Sometimes there is radiation. Usually it will occur substernally, either mid-chest, left chest, but that doesn't mean it can't be on the right side of the chest. It doesn't mean it can't be in the back. It doesn't mean it can't be symptoms in the neck. It doesn't mean it can't be symptoms in the jaw or other things, okay, what we call anginal equivalents, okay? When we talk about R means radiation, okay? So does it go anyplace else? That's what I'm just talking about. So the classic substernal chest pain with radiation down the left arm. Everybody knows that, okay? But you can also just get some discomfort up here. And the thing about discomfort up here is it could be any number of things. It could be reflux, it could be gas, it could be, any number of different things. And so if it's a real problem, okay, and it's something that's consistent, it has to get worked up in order to know, okay? You can have jaw discomfort in some people. You could have back discomfort, particularly around the area of the shoulder blades, okay? That's radiation. S is severity. So severity is on a scale of 1 to 10, how bad is it? And this helps us to determine, is your discomfort stable or unstable? So is your angina stable or unstable? So in other words, if walking up a flight of stairs for years has caused you to go to a 2 out of 10 chest pain, and now walking up that same flight of stairs causes you to go to a 5, 6, 7 degree of chest pain, well, that's considered unstable angina. If your angina is occurring more frequently, well, that's unstable angina. If your angina is coming on with lower levels of activity, well, that is unstable angina. If your angina is more severe than usual, that is unstable angina. So stable angina is predictable, okay? So many people live for years with stable coronary disease, stable angina, which means they get their chest pain, comes on with exertion, goes away with rest, okay? Comes on with the same level of exertion, same duration of exertion, same intensity, same frequency, once or twice a week. Now it's 7 times a week. Now it's every day. Now it's several times a day. That's unstable angina, and those things can indicate a progression of your disease and must be checked out. Must be checked out, okay? So that's severity. Timing. So is it intermittent or constant? Okay, another question I like to ask people is when it comes on, does it flip on like a light switch and then it flips off and it's gone? Or does it sort of ramp up gently as the exercise becomes more difficult? So does it ramp up slowly and progress and hit a crescendo and then go away as you stop? Because flip on like a light, go away like a light points to musculoskeletal or something else, okay, not the heart. And again, the thing that I worry about is you having a heart attack. That's the single most important thing that we want to prevent, okay? That's like the other side scored a touchdown on us, okay? Atherosclerosis, heart disease, got a touchdown. My goal is to keep the other team out of the end zone, okay? So again, think about that. Key points. You can have COPD and coronary disease. You can have pulmonary hypertension and coronary disease. You can have pulmonary fibrosis and coronary disease. So don't get the idea that everything that happens to you is your COPD or your pulmonary fibrosis or your pulmonary hypertension. So my feet itch at night, is that my COPD? And no joke, I actually see questions like that, okay? I actually see questions like that where people think that everything is their COPD or their pulmonary fibrosis or their pulmonary hypertension, and it's not. Now, COPD can definitely cause discomfort in the chest, okay? It can definitely, but the number one symptom of COPD is shortness of breath, okay? Can people start to feel this pressure if their lungs are hyperinflated, if they're becoming more obstructed as they do exercise? Absolutely. Okay, can they feel more pressure in their chest if they just had a giant meal and everything is pressing up on the diaphragm and pressing into the thoracic cavity? Absolutely. There's many, many things that can cause these sensations, which is exactly why we have to check them out when we see them, okay? What else? All right, so I think that is it for today. I think that answers that question. So again, if you're having any type of discomfort here, okay, even if you have COPD, even if you have pulmonary fibrosis, even if you have pulmonary hypertension, don't make the assumption that you know for sure what this discomfort is, especially when it's coming on with exertion or emotional stress or times where the supply and demand balance is going to be off. So all of this stuff is supply and demand, and it's all based on oxygen. Ultimately, it boils down to oxygen supply and demand. So in other words, when we're stressed, when the heart beats faster, when the heart beats more vigorously, when we're exercising, when the heart beats faster, when the heart beats more vigorously, etc., etc. All these things, okay, will require more blood supply. And that's where, if you do have atherosclerosis and if you do have blockages in the coronary arteries, they're going to show up. So they may not show up with at rest. They may not show up when you're sitting and doing nothing because your body may be perfectly capable of meeting the demand at rest. Similarly to oxygen saturation. So you may be perfectly saturated at rest when the demand is low. But once you get moving, that's where we start to see these symptoms being elicited of heart disease, lung disease. It could be any number of different things, okay? But the key is err on the side of caution, err on the side of knowing what your discomfort is coming from. Don't guess it. And don't be a hotshot, okay? One of the number one symptoms of people having a heart attack is denial, okay? Denial. Another thing, if you do wind up in a jam where you are getting chest pain or pressure or any of that, and it's not being resolved and you're having difficulty breathing, don't be a hotshot. Go to the emergency room, and don't take yourself to the emergency room, and ideally don't have a family member drive you to the emergency room. Ideally, call 911 so that paramedics can come to your place, causing you the least stress as far as physical stress of having to get yourself to the emergency room, and treatment can begin on site. Okay, so I hope that's helpful. Again, chest pain or pressure that could potentially be associated with coronary disease must be checked out. And tomorrow we will talk about rib cramping and rib pain. That's another one. Have a great day, everybody. Boom.